Good morning, everybody. Today we are talking about syndactyly in a quick review. I am Kamel Marouf, orthopedic surgeon, visiting surgical fellow in microsurgery and hand department with Professor Bulant and Professor Berkan. The normal web space is parameters that are used to judge the syndactyly are that it slopes in 45 degrees from dorsal to palmar direction from the metacarpal head towards the proximal phalanx midpoint. It usually extends approximately 2/3 the length of the proximal phalanx. As we know from embryology, webbing regresses in weeks 6 to 8 of gestation from distal to proximal direction. In syndactyly, the process, the abnormality of the process of apoptosis in the apical ectodermal ridge happens, which is signaled by the bone morphogenic proteins, tumor growth factor beta, fibroblast growth factor, and retinoic acid. But the exact mechanism is still unknown. The incidence of syndactyly is reported to be 2 to 3 per 10,000 births. Also, some reports go as high as 40 per 10,000. And it is the most common congenital anomaly of the hands. It usually happens in males as twice as in females, and bilateral cases has been reported in 40 to 50% of the cases. However, they might be symmetrical as in these images. Syndactyly can happen simultaneously in the hands and the feet in the same patient with symmetrical or asymmetrical occurrence. It also can be combined with other congenital anomalies like polydactyly or hypodactyly or symbrachydactyly. The etiology, as we said, it is largely hereditary. The genes that have been identified in the non-syndromic syndactyly, which is the least common type, there has been identified 11 loci and 8 genes for that. The environmental factors that are thought to play a role in the syndactyly are maternal smoking, lower nutritional status, lower socioeconomic status, and some reports have indicated that increased meat and egg consumption during pregnancy might play a role, but this is still not confirmed. In order to classify syndactyly, the OMT classification adopted by the IFSSH puts it as a malformation of the hand plate. A trial of classification by Malik, Temtami, and Makusik of the non-syndromatic syndactyly classified it into 9 types, taking into account the most common descriptions and families that were reported to have syndactyly in generations, and trying to identify and include the biological, molecular, and genetic variables in the classification. However, it is still in its infancy, and it is still heavily used, not heavily used in research to basically communicate between researchers. The most practical classification, and the one that is used by surgeons, is either complete or incomplete syndactyly, where the complete one means the involvement of the nail with synonychia, and the incomplete means the skin element without the involvement of the nail. It can be also classified into simple, complex, or complicated, where in simple we have only a skin element involvement. In complex we have bony element involvement, and in complicated cases it might include other syndromes and other body parts involvement and systems. The most commonly involved interspace is the space between the third finger or the fourth and fifth, followed by the second web space and the first web space, which is rarely involved. And usually when we have the radial web space involvement, it indicates an associated syndrome. To assess the patient with syndactyly, as usual, we start with a thorough history and physical examination to identify the associated occurrences of other systems. Hands and feet should be examined together. And X-ray role will help to highlight some of the bony abnormalities if they are present, but however, it is not accurate because, as we know, in children younger than 1 year of age, some cartilaginous parts will not show on the X-ray. The suggestion of the use of routine musculoskeletal MRI and ultrasound is still not justified and not used in common practice, but mainly used in research for research purposes and in complicated cases. When we go for surgery in syndactyly patients, we are aiming to separate the fused digits to create a normal web space and to improve both the function and aesthetics of the hand. Contraindications include mild, incomplete, not syndactyly not impairing function, medical conditions making anesthesia dangerous to the patient, and complex syndactyly where our surgery will disturb the function rather than improve it. So we should always keep in mind that the function is more important than cosmesis. Timing of surgery is a controversial issue. We need to be early enough to allow for normal growth, but we need to be late enough to avoid post-operative complication. Statistically, it has been shown that in younger than 1 year infants, the hypertrophic scar formation and contractures incidence is more, while if we wait more than 12 months, the asymmetric growth of the fingers might cause more deformation and angulation of the joints. Some special circumstances where we need to interfere early are when we have syndactyly between different sized fingers, like when we have it between the little finger and ring finger, or between the thumb and index, where we cannot wait for the growth as it will cause deformation and varus valgus angulation. When the distal phalanges are involved, usually we aim for earlier surgery to prevent the contracture of the tip of the finger and the pulp space contracture. If there are already flexion contractures in the fingers, we should interfere early, not to allow it to become fixed. If we have bilateral cases, bilateral hands, and we need to interfere, it is advisable to do that before the age of ambulation so that it can be protected and the child will not start moving on it and weight bearing on it. When we have numerous fingers involvement, we know that we are going to go for multiple surgeries, so we should stage our surgeries and we should start early and separate them by 3 months. So, and we need to start by the first web space and third web space, and followed in the second surgery by the second and fourth web spaces if needed. When we have both sides of a finger involved, this risks neurovascular status if we do it in one surgery. A lot of reports have reported even deformation and even gangrene in these fingers, so it is wise to do it in a staged procedure and start early intervention. The tips and challenges in the surgery is rising from the fact that the two separate digits have a circumference that is more than 22% the circumference of the syndactylized digits. The more distal the involvement passing the PIP joint, the more difficult the skin coverage will be and the more difficult the procedure will be. So the more proximal involvement is simple to be treated. A lot of techniques have been advised for soft tissue deficit closure. Skin grafting with both types, full thickness or split thickness, have been advised. However, split thickness have fallen out from favor because it causes more contracture. The full thickness has its own complications also of skin color, hair, etc. Some authors suggested leaving it to heal by secondary intention, and this also has some debate about the follow-up on contractures and recurrence or web creep. Tissue expansion have been used by some authors, but it is still not popular. It did not gain the popularity for syndactyly treatment. The newer techniques and the new literature is more towards graft-free closures using the modification of graft flap design to allow for avoidance of all the previous options. Flap design have been evolving through the past 100 years. In the 19th century, it was simply cutting the web space using scissors while the baby in the nursery. Then Cronin's technique started to evolve in the early 20th century by simply splitting the fingers under GA, and that had its own complications. So Z-plasties, rectangular, triangular, omega, multi-lobed shaped flaps all have been advised. Sharma's modification, open finger technique of Withy, these all were modifications to try to avoid the complications of contractures and stiffness and web creep. There has been surging preferences of use of dorsal versus palmar skin. Usually the dorsal skin is easier to ambulate and easier to get in the web space, but the palmar skin have the advantage of being more thick and better prevention of web creep. Pedicle dorsal metacarpal artery flap was also advised to provide coverage without contractures, and defatting technique of the flaps have also been advised, and it has been suggested that the defatting technique is the more important in prevention of future complications, and it is best done in babies between 3 to 6 months of age. It was summarized in this paper by Brown, Trost, and Pedersen, and it is really nice for anyone who wants to go into further details and look into these schedules. Other challenges in syndactily separation is mainly rising from the digital artery bifurcation, which is the main limiting factor of going back with the web recession. Usually one digital artery is enough for the digit to survive. If you are sure that the other digital artery is functioning or it is normal and you don't need to go for it, you can ligate the artery bifurcation and go further with the web space recession. Otherwise, you might need to put some venous graft to bridge the gap and maintain your digital artery. The digital nerve is better in terms of ambulation. You can just release it from its bed and move it more proximally, and it will work well. As we said earlier, the defatting should not be very aggressive in order to prevent gangrene and sloughing of the flaps, but it should be enough to allow for the proper closure and proper appearance in the future. The nail fold reconstruction is also challenging, which needs special techniques and special use of flaps from distant places, or even sometimes from other fingers or extra fingers or from the toes. Reconstruction of the web space has the challenge that it has its own musculature, and we need to preserve the opposition and the thumb movement when we reallocate the muscles and the ligaments into their proper place. In some instances, amputation might be the helpful options, especially when there is an accompanied polydactyly. Postoperatively is very important in syndactyly, as it has been shown that the dressing have a very large impact on the favorable outcomes of the flaps and survival. Formal physiotherapy is usually not needed. Some new authors have advised the use of methotrexate to avoid the recurrence of the deformity and web creep, but this is still debatable, and still it has to go for further verification in the future. The complications can be summarized into the most common complications of web creep, contractures, hypertrophic scar, discoloration, and abnormal hair growth in skin grafts. Withy has advised a classification of the web space where it goes into just thickening of the web space without any advancement, and then 1/3, 2/3, or whole length of the PIP joint. And Tonkin tried to advise a method to properly measure this web creep on volar and dorsal aspects, to quantify it and make it a communicable way in researches in the future. The other complication is the need of multiple surgeries, whether to do it in staged procedure or to treat complications in the future. And it has been reported in some researches to reach up to 60% of incidence of repeating the surgery for complications. In distal syndactyly, we have the issues related with the pulp and nail fold deformities, scarring, or absence. The other long-term complications include complications of the finger motion, whether stiffness or instability, neurovascular injury, poor venous drainage with overzealous defatting, or especially over the dorsal aspect, withered finger appearance, cold intolerance. All of these have been reported. Surprisingly, infection has been reported in hand in syndactyly release, mostly related to the young age of the patients, as in one paper they mentioned that their child would dip his hand in the toilet and got infection and had to go for revision. The final note about syndactyly is that since it might happen in the foot, it needs to be reconstructed there also, and we have some differences that were addressed beautifully last year by this paper published by Langjarmekron and et al. They indicated that the main difference is that the foot web space had a higher slope angle, less abduction angle, and shorter proximal phalangeal length, which meant that the design for foot web space requires a longer and narrower flap than the design of the hand. Thank you for your attention. And as usual, thanks for our references for providing us with knowledge that we had presented today. Thank you.